in the APAC Cardiovascular Disease Alliance, it's our pleasure to welcome everyone to the launch of our new white paper, Improving Heart Failure Policy and Management in Asia-Pacific and Opportunities for Impact. Heart failure is an urgent and growing public health concern in Asia-Pac, driven by demographic shifts, longer life expectancy, and the rising prevalence of conditions such as hypertension and diabetes. It now affects more than 30 million people across our region, a number that is only set to rise. Beyond its clinical impact, heart failure places enormous pressure on families through out-of-pocket costs and caregiving needs, and on economies through lost productivity and increasing health expenditures. In middle-income economies such as China and Thailand, heart failure accounts for more than 10% of current health expenditure, while in high-income economies like South Korea, estimates reach up to 8%. These combined burdens remind us that heart failure is not just a medical issue, but a societal one, and it demands urgent, coordinated action. I'm Kavita Rekraj, and I lead our life sciences and healthcare practice for Deloitte in Southeast Asia and Asia Pacific. And this white paper is a result of a truly collaborative effort combining the alliances and Deloitte's research and analysis with the inputs and endorsements of many distinguished experts across Asia Pacific. We're truly grateful to the key opinion leaders in cardiovascular disease, heart failure, and cardiometabolic care who contributed their expertise to make this report possible. The aim of the report is clear: to shine a light on the current policy and management landscape for heart failure across the region, to identify key gaps, and to set out opportunities for governments, health systems, and stakeholders to drive meaningful impact for patients. We go to the next slide, please. So I'd like to introduce today's agenda. We'll begin by providing opening remarks from Dr. Krishna Reddy of the APAC CVD Alliance, who will then provide an overview of the Alliance's mission and how this white paper fits into its broader cardiovascular disease workstream. My colleague, Yong Ho, will then share the main findings and recommendations of the report, before we hear from our esteemed speakers on case studies. Professor Hong from Taiwan, who will share insights from Taiwan's national heart failure policy, and Professor Kunigawa from Japan, who will discuss Japan's experience and leadership in integrated heart failure management and biomarker utilization. We will also then introduce Next Steps, a series of local heart failure policy roundtables in Hong Kong, Thailand, Taiwan, and Vietnam to help localize these recommendations and translate these into concrete action. Before we close with a round of Q&A and reflections. Next slide, please. Once again, thank you for joining us today. We hope this discussion will inspire all of us to work together towards stronger heart failure policies and better outcomes for patients across Asia Pacific. With that, it's my pleasure to hand over to Dr. Krishna Reddy. Dr. Reddy, please.
Yeah, thanks, Kavita. At the outset, it's a warm welcome from my side on behalf of the Asia Pacific Cardiovascular Disease Alliance. To introduce myself, I'm a cardiologist. I'm the Chief Executive Officer for Access Health International, which is a global think tank, nonprofit, and a knowledge partner. The APAC CVD Alliance was conceived, I think, around September 2022, with the objective to bring the needed policy attention and policy action for the rising burden of the cardiovascular disease and the rising unmet needs of people with cardiovascular disease. It was formally launched in June 2023. At the outset, it carried out a white paper for the overall burden of the cardiovascular disease in the entire region, as well as nation-specific analysis for about 8 focus countries in the region. And that white paper was launched in September 2023. The overall objective is to convene all the key stakeholders, whether it is researchers, the health professionals, the patient organizations, the civil society organizations, the healthcare provider groups, the health payers, that is both public and private health insurance people, some of the global health agencies, including the WHO, as well as the policymakers, both at the regional level as well as at the national level. The idea is to present the evidence that was published as a white paper, as an overall CVD burden, and crystallize some of the actionable solutions that emerged out of not only the white paper, but also through policy dialogues convened at a regional level as well as at the national level in India, Thailand, and Malaysia. The key milestones have been the white paper dissemination was followed by a large regional event of Heart Summit in Bangkok in 2024, followed by a series of national policy dialogues convening of all the stakeholders in Thailand, India, and Malaysia, with plans for Indonesia and South Korea this year. As a part of these key recommendations, I mean, some of the things were specific to the cardiovascular disease, and some of them were generic to the health systems in general, as well as community level interventions in general, which included the health literacy, the dominant involvement of health literacy and community engagement. The second was in terms of sustainable innovative financing, especially to access the rapidly emerging innovations to the cardiovascular disease control, both prevention as well as curative. While these recommendations are being disseminated and articulated in various fora, both regional as well as national, the Alliance also identified certain priority areas, which included, of course, the broader dominant priority of atherosclerotic cardiovascular disease, which accounts for 50% of the cardiovascular disease burden. But importantly, the heart failure again was brought as one of the top priority areas, for the simple fact that even though it accounts for 10% of the cardiovascular diseases, which is growing rapidly, it accounts for more than 50% of hospitalizations, more than 50% of premature deaths, and more than 75% of cardiovascular health expenditure. So that's the reason, I mean, why the heart failure assumes a priority. And this white paper, I think, which is an effort of and contribution from the various experts in the region, we are going to listen to some of the key findings and also some of the key. Personally, before closing, I thought 3 areas that emerge very strongly from the white paper. One, of course, is a gross underutilization of early detection in the stage B of heart failure, that is pre-symptomatic. I mean, that is the golden opportunity to diagnose, detect, and then control all the risk factors which actually contribute to the progression to the advanced stage of heart failure. We have very simple clinical methods, the imaging methods, and widely available biomarkers, which we are not utilizing. So that was one key lesson that came out of it. The second, I mean, despite availability of multiple solutions now, both the drugs and the devices, the adherence and application of these evidence-based therapies, proven tests and therapies, is abysmally low, below 20% of the population with heart failure. It's not because of access, it is because of lack of coordination, the need for multidisciplinary team approach. So that's why one of the strong recommendations is how do we evolve the models of care which ensure the continuity of care of heart failure as well as ensure adherence. And lastly, I think one of the challenges which the Alliance is trying to address in CVD in general, but heart failure in particular, is how do we address the sustainable financing challenges for the region? There are a lot of innovative solutions. I think we presented in the Heart Summit as well. what could be the innovative solutions for financing the rapid advances in heart failure management, including heart replacement, mechanical heart replacement as well. So with this, I think summary, I thank Deloitte as well as the Roche for giving this opportunity to take it up as one of the priority areas of APAC CVD Alliance. Thanks, everyone. We hope that we learn a lot from the white paper as well as the discussions. Thanks again. Over to you, Kavita.
Thank you. Maybe we move on. Before we move on, Catherine, you have any question or anything to add? Catherine?
No, it's all good. Thank you.
Okay. Okay, so let me take over and let me continue. So today, I will walk you through the key findings from our white paper on heart failure management in APAC. We will cover three main areas. First, the methodology used. Second, selected insights from the evaluation of the heart failure policy and management. And third, regional recommendations for improvement. Let me begin with the methodology. Our white paper uses a scorecard approach to assess the heart failure landscape across some selected APAC territories. This approach helps us identify strengths, challenges, and areas for improvement. The scorecard is based on the targeted literature review and expert panel input. It provides a foundation for actionable recommendations to enhance advocacy and management across the region. The scorecard consists of 5 domains, 34 subdomains, and 84 indicators. These domains include policy and planning, prevention and screening, diagnosis and resource capacity, treatment and access, awareness and education. Each domain captures the critical aspects of the heart failure policy and management, from national strategies to patient engagement and provider training. We worked closely with an esteemed advisory panel of experts from across APAC. Their insights were invaluable in shaping the scorecard and recommendations. This collaborative approach ensures that our findings reflect real-world challenges and opportunities in the region. Here is an overview of how APAC territories perform across the 5 domains. High-income territories generally show stronger performance, particularly in national CVD policy and treatment access. However, gaps remain in prevention, screening, and awareness. Middle-income territories face challenges in infrastructure, training, and equitable access. So these disparities highlight the need for tailored strategies. 5 out of 8 territories have dedicated national CVD strategies which enable better coordination. However, gaps persist, such as absence of the national targets and fragmented registries. High-income territories demonstrate stronger financing and infrastructure, while middle-income territories struggle with limited funding and weak implementation capacity. This table summarizes CVD policy components across the territories, including standalone policies, targets, registry, financing, and equity measures. While most high-income territories have robust frameworks, middle-income territories show variability, particularly in financing and registry systems. Heart failure-specific policies are quite rare. Taiwan stands out as the only territory within a national heart failure policy under its health insurance system. Other territories integrate heart failure into broader CVD strategies, but implementation is fragmented. Limited guidelines, uptake, and weak secondary prevention remain common challenges across APAC. Heart failure screening is included in guidelines for most high-income territories with biomarker-based screening in Japan and Korea. However, funding and reimbursement gaps persist, especially in middle-income territories. Taiwan demonstrates strong coverage and partial reimbursement, serving as the best practice example in APAC. Diagnostic guidelines exist in most territories, but biomarker use remains limited. Multidisciplinary care models are emerging, particularly in Japan and Korea. Reimbursement restrictions and narrow the biomarker panels are key barriers in several territories. Comprehensive the treatment guidelines are in place in high-income territories, covering both GDMT and monitoring. However, gaps include underfunded biomarker reimbursement and limited emergency care protocols. Middle-income territories face challenges again in providing team-based care and full drug biomarker funding. Patient education materials are available in most territories, often via NGOs or societies. However, heart failure-specific patient organizations are quite rare in APAC, again, and providing training is inconsistent. In Korea, Vietnam, and Hong Kong stand out for strong awareness campaigns and active heart failure societies, but the heart failure-specific awareness has not yet fully built in most other territories. Based on these findings, we propose regionally relevant recommendations tailored to the system maturity and feasibility. Our focus areas are early diagnosis through primary, tertiary collaboration using NT-proBNP, strengthening long-term heart failure management, financing, and shifting tasks to primary care. To improve early diagnosis, we recommend integrating heart failure screening in primary care and diagnostic confirmation in tertiary care using NT-proBNP. Enhancing primary care tools and raising public awareness are critical. Targets including 50% NT-proBNP coverage among high-risk patients by 2027, 15% reduction in delayed diagnosis by 2028, more than 50% facilities equipped with NT-proBNP by 2028, and reducing misdiagnosis by 20% by 2030. For long-term management, we propose establishing multidisciplinary heart failure clinics, leveraging telecommunications and adopting digital tools for remote monitoring. Our goal is to increase GDMT adherence by 30% and reduce heart failure mortality by 15% by 2029, achieving above 60% of the hospitals provide GDMT by 2030 and 25% rural heart failure hospitalization reduction by 2030. We recommend securing sustainable financing through heart failure-specific strategies and promoting task shifting to primary care. Targets include allocating at least 10% national CVD budget to heart failure and training over 500 heart failure specialists by 2029. Implementation will follow a phased approach: short-term pilots, mid-term standardization, and long-term expansion. Monitoring will occur at regional, national, and provincial level, supported by transparent dashboard and accountability tools. Short-term, if we look into implementation directions, short-term, which is within 1 to 3 years time frame, launch pilots in mature systems such as Australia, Japan, and Korea using existing infrastructure. And this includes NT-proBNP screening and heart failure clinics. For mid-term, which is 3 to 5 years time frame, standardized diagnostics and treatment protocols across the region. And this means the point-of-care testing, guideline-directed medical therapy, and telehealth integration. For long term, which is 5 to 10 years, it expands the public awareness campaigns and digital care models and build a robust data system like heart failure registries and interoperable electronic the health records. Decision to enable this, we need strategic enablers. So national heart failure registries and interoperable EH, the electronic health records, and public-private partnership for diagnostics and workforce training, and regional collaboration platform for knowledge sharing. And monitoring will happen at multiple levels. So regional levels, cardiology societies, donors, and multilateral partners will coordinate benchmarking and capacity building. At national level, ministries of health will integrate key performance indicators into health system and mandate annual reviews covering anti-pro-BNP coverage, GDMT adherence, and specialist training. At provincial levels, departments and hospitals will report regularly to address local gaps and monitor the service delivery. So we will use accountability tools like a transparent dashboard, as you mentioned earlier, and joint mechanism to keep stakeholders aligned and responsive. Finally, our strategic anchor is early detection, community-based care, and sustainable financing. These from the roadmap for the improved heart failure outcomes in APAC. Thank you for your attention, and I would now like to invite Professor Chung Lee Hong to share a case from Taiwan. Over to you, Professor Hong.
Good afternoon, Chairperson, ladies and gentlemen. Yeah, this is Dr. Hong. I'm presenting the data about cardiovascular disease and heart failure prevention policies in Taiwan. Please see next slide, please. Overall, I want to introduce here the domestic GDMT prescription data from Taiwan Heart Failure Registry Program from 2013 to 2014. We reported 1 year outcome of acute decompensated heart failure in Taiwan from our TSOC Heart Failure Registry. Next, please. In our registry, we can see that compared to other area or regions or countries, Taiwan Heart Failure Registry enrolling systolic heart failure tend to be younger and more likely to be male and less comorbidity. Importantly, we also would like to show that the use of GDMT was a little bit lower, and the use rate was less than other countries or regions during the same period. Concerning medication at discharge, adherence to using a renin-angiotensin system blockade was lower, but adherence rate to beta blocker and MIA was similar compared to other registries. Also, we want to point out that the percentage of severe heart failure on admission was highest in Taiwan among these registries. The utilization of electronic device therapy in Taiwan during the index hospitalization was low compared with that in Europe and Japan. Please see next slide. Next, please. And the next, please. Shown here, the data of the use of the foundational therapy in Taiwan from two different large registries. Please see above slide, previous slide, please. Yeah, for this one, we can see in the left panel, we can show the data of our TSOC Heart Failure Registry as reported, as mentioned above, from 2013 May to 2015 October. We can see that in Taiwan, our registry show that the use of RAS blockade, beta blocker, and MIA could be a little bit under 60% overall on average. Compared to other regions and countries, the use of beta blocker and MRA could be comparable, but the use of ROS blockade was much lower. When you see the right panel, another data from Asian heart failure registry about the heart failure reduced cohort between 2012 and 2015. We can see again the use of GDMT comparing to other regions and countries were a little bit lower, including the ROS blockade, beta blocker, and MRA. This data indicated the utilization and implementation of GDMT in systolic heart failure in Taiwan should be much more improved. Next slide, please. Another platform that in Taiwan, particular to special to other countries, that we have seen that the core concept of heart failure APAC program and the management for acute heart failure patient in our country. This is a nationwide platform, and also this is start from the care of nursing care, the implementation of nursing care and intensive pharmacological use in Taiwan 3 to 6 months post-acute phase of heart failure, and go into the chronic stable period in the outpatient ambulatory setting. Please see next slide. The National Health Insurance Program in Taiwan commenced in 1995. National Health Insurance is a single-payer system that covers 99% of a population of 23 million residents in Taiwan. The first PAC program that was covered by National Health Insurance in Taiwan was launched in 2014. This program supported patients hospitalized for acute stroke and was successful. In 2017, PAC was extended to patients with heart failure hospitalization. So heart failure PAC program in Taiwan is a national policy-driven multidisciplinary disease management platform reimbursed by National Health Insurance. They provide comprehensive continuous care from pre-discharge to ambulatory care for a period of 6 months after discharge. Patients who had been hospitalized for acute or decompensated heart failure who had an ejection fraction less than 40 were discharged following hospitalization and aged 18 years or older were eligible to be enrolled in the heart failure PAC program in Taiwan. Once enrolled in the heart failure PAC program, patients were treated by heart failure physicians and specialty nurses from the heart PAC team with continuity of care up to the end of the 6 month period. Next, please. Shown here is another data from Taiwan mentioning about the heart PAC program and National Health Insurance in the care of acute heart failure. We can see that in total, there were 19 medical centers involved in this platform, and 82 regional hospitals and up to 362 community hospitals participate in this heart failure PAC program. Please see next slide. By using the retrospective propensity score matching method, the Taiwan cohort conducted a study using the National Health Insurance claims data to evaluate the all-cause mortality, emergent visit and length of stay, and the mission medical expenses of heart PAC group compared to a control group. The study period was between 2017 to 2021. Originally, our cohort consisted of 150,000 of patients drawn from hospitalization reimbursement claims. Of these, 2,173 patients participated in the heart failure program compared to those without as control. Please see next slide. So we compare the policy-driven post-acute care program, which is a platform from Taiwan National Health Insurance Program, and which implement a platform for acute heart failure in Taiwan compared to those without enrollment. We showed in the data the difference before matching and after matching. We can see that for patients enrolled in the heart PAC program after matching had comparable clinical baseline demographics, including the age, sex, and the comorbidity burdens. Please see next slide. So only one difference is the GDMT utilization and ICD rate in the HAPAC program in Taiwan. For the 2,173 patients enrolled in the HAPAC program, we see that the ROS blockade use rate was significantly higher compared to the control. The same situation also applied to the use of beta blocker at MRA and also the combination of 3 combined ROS blockade, beta blocker, and MRA. On average, the total use rate of GDMT was 10% higher in the patient enrolled in the HAPAC program compared to the control group. Please see next slide. The successful implementation of GDMT in the HAPAC program can also result in a successful outcome regarding the patient's all-cause mortality and heart failure hospitalization. Shown here, we show that after mentioned, during a median follow-up of 1.6 years, a total of 800 patients died. The mortality risk in the HAPAC program was significantly lower compared to the control group. It was nearly 15% versus 26% with statistical significance. The HAPAC program reduced mortality risk by up to 48% with statistical significance again. And shown here is the subgroup analysis. We see that there was no P4 interaction regarding any subgroup for the treatment efficacy for the patient enrolled in the HAPAC program compared to the control group. Please see next slide. Next, please. Again, next, please. Okay, here. And I would like to show another new heart failure registry in Taiwan. Please go back to previous slide. Yes, this one is the domestic GDMT prescription in the Taiwan New Heart Failure Registry program from 2020 to 2022. Next, please. Please go back to previous. Yes, yes, here, yes. So the new data from the Taiwan Society of Cardiology initiated the Taiwan Heart Failure Registry program from 2020, which is again a multi-center new prospective and observational study on Taiwanese patients with heart failure. The current registry program involved a total of 27 hospitals. The inclusion criteria for the current study were for those above 20 years old with a clinical diagnosis of heart failure, and also for PATH phenotype, the patient should fulfill the following criteria of modified HAPAC score larger or equal than 5, and for reduced heart failure, the ejection fraction should be less than 40. Please see next slide, please. In this new heart failure registry program, we can see that the new registry show that the GDMT use of the Taiwan Society Heart Failure registry starting from 2020, which indicate the yellow bar has substantially higher use of GDMT compared to other registry, which could be older registry compared to current Taiwan heart failure registry. We show that the ROS blockade use of the beta blockade and MRA utilization rate was significantly larger and even larger than previous and older registry. For the diuretics, we also show that the use rate was a little bit lower compared to other registry, and that the digoxin was also lower compared to other registries. This indicates the successful implementation of GDMT in Taiwan after a new policy of HAPAC program, and also in the current new era and in the paradigm shift of heart failure care of Taiwan by conducting a new registry and a new platform for heart failure care. Thank you for your attention.
Thank you, Professor. So now we would like to invite Professor Koichiro Kinugawa-san to present a case from Japan.
Hello, everyone. So thank you for a kind introduction. So I'm Koichiro Kinugawa, the president of the Japanese Heart Failure Society. So in this webinar, I'd like to introduce the current status of heart failure treatment in Japan. The next slide. So this is my disclosure. So next slide, please. So looking at the pie chart, you can see that the heart failure is the leading cause of death due to cardiovascular disease in the country, first surpassing deaths from acute myocardial infarction. The line, next, please. Yes, the line graph on the right shows the annual trend, indicating that around the year 2000, the leading cause of death shifted from myocardial infarction to heart failure, and the gap has been widening ever since. Next slide, please. Especially among the elderly aged 65 and over, the number of the de novo heart failure has been increasing continuously to the point where it is referred to as the heart failure pandemic. Currently, there are approximately 350,000 new cases of heart failure annually. Next slide, please. Next, thank you. The bar graph shows the population distribution in Japan, indicating that while the total population has been declining since 2020, the population of elderly people aged 75 and over will continue to increase until 2055. The line graph estimates the total number of heart failure patients, which is currently believed to be at least 1.3 million. Next, please. The left graph is a registry from the early 2000s, showing that the average age of heart failure patient was 71 years old, with less than 30% being over 80 years old. On the other hand, the right graph is a registry from the 2010s, only 10 years later, showing a clear aging trend with an average of 77 years old and about half of the patients being over 80 years old. Next, please. So this has also led to significant changes in the distribution of LVEF, with HFrEF being predominant in the early 2000s, but by the 2010s, HFpEF patients accounted for about half. This rapid increase in aging and HFpEF can be observed. Next, please. The 30-day and 1-year readmission rates for heart failure patients in Japan are shown. The numbers have remained flat and are not very high, but they cannot be said to have improved. Next, please. The in-hospital mortality rate is low, and the average length of stay has recently been around 2 weeks, but the 1-year mortality rate is on the rise. This may be an inevitable phenomenon due to aging, as it remains unchanged when this number is age-adjusted. However, overall, the prognosis for heart failure patients in Japan has been stagnant for about years. Next slide, please. So the estimated medical cost for 2021 are shown. Cardiovascular medical costs rank first for all ages, but when limited to those aged 65 and over, the gap with the second place widened further, with about a quarter of the cost being consumed by cardiovascular diseases. Next slide, please. So there is little real-world evidence on GDMT in Japan, but the Evolution-HF study provided shocking data that RAS inhibitors and MRAs, once introduced, are discontinued after 1 year more frequently in Japan than in Sweden or the United States. Next slide, please. So our Heart Failure Society recently issued a statement recommending the use of BNP or NT-proBNP values as a guide for optimizing drug therapy in outpatient settings. Of course, concerns about drug side effects are likely a major reason for discontinuation, but I believe that if there is a stance to adjust GDMT so that the patient BNP does not rise, it would not be discontinued easily. Next slide, please. So our recently revised heart failure guidelines also recommended BNP-guided therapy in heart failure patients as Class 2A. Next slide, please. Additionally, the statement emphasizes the importance of identifying and intervening at the pre-heart failure stage before heart failure develops. It suggests that if BNP greater than 35 or NT-proBNP greater than 125, even at relatively low values, appropriate measures should be taken based on the background of the patient. Next slide, next please. So this is a pamphlet recently created for distribution to general practitioners. It provides specific methodologies, for instance, for the patient stage A, where BNP or NT-proBNP has not yet risen, and there is only at risk, but we recommend measuring BNP or NT-proBNP once a year, and if it rises above the threshold, let's say 35 or 125, measuring it twice a year. Next slide, please. Furthermore, the pamphlet goes a step further than the guidelines in recommending drugs based on the patient background. I hope you will find it useful. So next slide, please. So this is my last final slide. So take-home message from these presentations are, in Japan, there is a definite increase in elderly and preserved EF patients with heart failure. Medical cost for cardiovascular disease is tremendous, and it may partly be due to the long hospital stay. It is pertinent to prevent rehospitalizations, but GDMT is unsatisfactory, especially in outpatient clinic situation. Utilization of BNP-guided therapy in outpatient clinic might be helpful for optimization of GDMT. More importantly, we have to act proactively to prevent heart failure per se, and early detection of stage B pre-heart failure by regular surveillance of BNP or NT-proBNP among patients with common diseases, for example, hypertension, lipid disorders, or ischemic heart diseases, or type 2 diabetes, might reduce future incidence of de novo heart failure. Thank you for your attention.
Thank you, Professor Kinugawa. Now I would like to invite Dr. Reddy again to share the next steps. Dr. Reddy?
Yeah, thanks, Ango. We have heard very impressive presentations from both Taiwan as well as Japan, with a convincing evidence in terms of the benefit of early diagnosis. I think that was very clearly coming out, not only early diagnosis, but the upstream risk factor optimization and adopting the emerging concept of the cardio-renal-metabolic syndromes. I think that has been brought out very well in the previous presentation. While I think everyone is among the cardiology professional circuit are aware of the rising burden of the heart failure, as well as the implications, both health-wise as well as economic-wise, for the countries and the region on account of the burden of heart failure. What is needed on behalf of the Alliance is to translate this evidence, both which is available through the expert opinions as well as a systematic research, how to translate this evidence into needed policy attention at the regional level and at the national level. Since most of this has to be translated into the national action plans at a national level, I think as we have seen from the white paper summary presentation, while many countries in the region have national action plans for non-communicable diseases in general, few countries have specific action plans for cardiovascular diseases, and very few, hardly 1 or 3 countries have specific national action plans for heart failure. The second gap would be that even though the countries may have action plans for both cardiovascular disease as well as heart failure, but there are very many gaps that are evident when you undertake systematic research, that there is a huge implementation deficit in many countries in the Asia-Pacific region. So there are gaps in the national plans, but there are greater gaps in the implementation of the plans. So these issues can be brought out when the action gets shifted to a country-specific dialogue. I mean, if the dialogue between key stakeholders, especially the patient organizations who actually experience the burden of the disease, the researchers who generate evidence to convince the policymakers, the healthcare providers, because both public sector as well as private sector, as to how they can adopt some of the evidence in revising their existing models of care, and also life course approach to the entire cardiovascular disease from promotion to palliation. So the actions at a national level, in addition to the policy actions, there are also actions which can be undertaken by the other key stakeholder groups, because the cardiovascular professional groups can come up with the health education material, can come up with guidelines, the national guidelines, and since they have enjoy access to the policy makers, they are best positioned to advocate the attention and action on the heart failure. So with these things in mind, there are plans at a national level, action plans, territory-specific audit preparation, as well as execution and white paper updates. So these are the timelines. In October, of course, today we are launching the white paper. Then November, we have one country-specific policy dialogues, multi-stakeholder dialogues, followed by December. And then in January, we will be taking up 2 more countries. The 4 priority countries out of the 8 countries, both Taiwan, Japan, Thailand, and Vietnam. These will be taken up in series from November to January to amplify some of the evidence that is generated and amplify some of the insights derived from the discussion today. We hope, I mean, this white paper, when it is disseminated across all the stakeholders in the region, will gain the attention, will gain interest, and the national level policy dialogues will consolidate some of the gains through this dissemination. So we hope that more and more stakeholders join this alliance so that there is a shared objective of bending the curve of cardiovascular disease, bending the curve of heart failure, and preventing progression of heart failure rather than trying to address, because we have seen actually the mortality rates have become flatter, despite, of course, though the studies are dated, We have more advances in therapies as well as the devices. But despite these advances, even the recent publications, when we look at, the outcomes continue to be not optimal. That means there is a lot more things to be done in addition to bringing out innovations. It may be because of awareness, it may be because of access, it may be because of affordability, or it may be because of acceptability. So these are the things which can be addressed at the national level. So as a part of the alliance, we hope that we continue to pursue and persevere on this shared objective, that can we collectively impact the CVD burden in the Asia Pacific region, and indirectly and directly, we also impact the economic potential now that rests within the Asian age or Asian millennium that may be affected if we don't address the cardiovascular disease burden as well as the heart failure burden. I think with this update and information, again, thank the Deloitte for this opportunity for me as well as the APAC CVD Alliance to co-host this launch of the important white paper. Thank you all.
Thank you, Dr. Reddy. So would you like to invite anyone who has any question about our white paper or any specific content? So please raise your hand. Then we'll be happy to have your the questions. Is there any question? So previously we had a question about when the report will be available to public. We have shared the link in the chat and also Q&A as well. So you may access the report via Deloitte website or CVD Alliance website. If there is no further question, maybe I will invite Kavita to share the few final slides and close the webinar. Kavita.
Thanks, Yongho, and thanks, Dr. Reddy, and our esteemed speakers. So as we come to the close of today's webinar, I'd like to once again thank all our speakers and you, our participants, for joining us and sharing, some of you we've also connected with and getting your valuable perspectives on how we can advance heart failure management across the Asia-Pacific region. And for those of you who wish to explore our findings and recommendations in more detail, as Yongho said, the full report is now available on both the APAC CVD Alliance and Deloitte websites. The links have been shared in the chat, or you can also scan the QR code that we're currently displaying on the screen, or you can also search for the report online. If you have any issues, please don't hesitate to reach out to us. And we further welcome any further discussions on how we can collaborate to improve heart failure management in Asia Pacific. Feel free to reach out to us or the Alliance, and we'll be keen to explore opportunities on how we can work together towards driving better patient outcomes. Now, as we wrap up, in closing, heart failure, as we know, is not a momentary or a seasonal issue that will fade in the coming months or years. It's a reality that continues to affect our communities. We hear about heart failure and may even witness it personally among those we care about. The time to act is now, to work together to strengthen the prevention, enable early detection, and improve the management and monitoring of heart failure for a brighter and healthier future for all of us. Thank you once again for joining today's webinar, for your interest, for your participation, and your continued support in advancing cardiovascular health across our societies. Thank you.
Thank you, everyone.